Dr. Neetu Mohan is the Chief of Glaucoma Services at Aravind Eye Hospital, Chennai. She is a very good teacher, and she will be talking to us about BANG, KDB and Tanito hook. That is the bent angle needle gonioscopy, the Kahook dual blade and the Tanito micro hook. Thank you, Dr.
Good afternoon, and thank you, Dr. John and KSOS for the opportunity to be here today. So I was hoping to be part of this young, vibrant team. One person is missing, but still it's good to be part of a young team. So I'm just trying to share some of the learnings that we have had in the past 1.5 years since we started MIGS. So these 3 surgeries are probably one of the first surgeries that can be tried when you are trying to start MIGS. Of course, as John described, visualizing the anterior chamber angle, surgical gonioscopy, and just getting the feel of going and touching the trabecular meshwork with the Sinskey are the initial steps. And after that, once you are comfortable with the visualization, these are probably the first steps that you can take towards MIGS. So we know all these 3 techniques, the KDB, the BANG, and Tanito micro hook, essentially addresses the resistance at the level of the trabecular meshwork. And this is where we know there is maximum resistance in open angle glaucomas, in primary open angle glaucoma, and the collector channels are densest in the inferonasal quadrant, which is why all these techniques address the nasal quadrant. So as described, these are best in mild to moderate open angle glaucomas. Having said that, there may be more indications which may be revealed in future, but as of now, we offer this for mild to moderate open angle glaucomas. So this is one concept that we need to understand. This is the episcleral venous fluid wave. So at the end of surgery, if you can actually visualize an episcleral venous fluid wave, which is blanching of the episcleral vessels when you do an AC wash or when you hydrate the chamber, that is an indication that the MIGS may work well in these eyes. But this, of course, is done only at the end of the surgery, so we don't really know before surgery what are the prognostic factors in terms of outcomes, but this is one thing which will tell you that the MIGS in this patient will probably work well. So coming to the KDB or the Kahook dual blade, this is essentially a handheld knife which is designed to engage, stretch and excise a strip of the trabecular meshwork. It does an excisional goniotomy with less collateral damage to the posterior wall of the Schlemm's and the adjacent structures. So the distal tip engages into the Schlemm's canal and the trabecular meshwork is elevated onto this ramp that you see here, and it is fed to these dual blades which removes a strip of the trabecular meshwork. So the technique as described, the head over heart will reduce the bleeding into the eye, reverse Trendelenburg position, just 20 to 30 degree head over the heart. And we usually combine it with cataract surgery. After cataract surgery with IOL implantation, intracameral Pilomine or Carbachol will allow better visualization. Utilize a clear corneal wound from cataract surgery and a cohesive viscoelastic in the anterior chamber to deepen the nasal anterior chamber. Patient's head is rotated 35 degrees 35 degree away from the surgeon, and the microscope as described is rotated 35 degrees towards the surgeon. We also have these positions marked on the microscope, and there are apps available on the Android and on the iPhone. I think on the Android it is angle meter. You can actually mark the normal position in which you operate in and the position that you want for MIGS, so that your assistant can help you to quickly change the positions when you are switching from MIGS to cataract surgery. A cohesive viscoelastic on the cornea. A Catena lens which comes with the Kahook dual blade is what we usually use. A Schwann-Jacob lens will also be good. And as described, the KDB is slid into the Schlemm's canal and then you excise a strip of the trabecular meshwork. So essentially there are 3 approaches to this. One is mark and meet, where you mark the end point of your goniotomy and then you come back and start as far away from that as possible, and you keep moving till you reach your end point. Or you could do outside in, where you start from the extreme as far as you can get on either side and come and meet in the center. Or you could do inside out. Depending upon your comfort level in that particular patient, you can decide which approach you want to do. So this is KDB glide goniotomy in a patient which for some reason did not have much of a bleeding during surgery. So I thought this may be a good one to see the technique well. So it is good to have the microscope foot pedal comfortably positioned so that you can zoom in and out every time you want. Introducing an instrument, better to zoom out once you are focused. This is mark and meet. I am marking the end point of the goniotomy here. And then coming as far I can towards the inferior nasal angle. Slide into the Schlemm's canal. It engages into the Schlemm's canal and try to keep the focus as you do the goniotomy. I've lost focus here, moving the joystick of the microscope, focusing well, and then engaging. You can see the trabecular meshwork being lifted off, and since it's heavily pigmented, it's very well visualized in this case. The trabecular meshwork is lying over the iris here. Again, changing the focus, focusing well. It's very imperative to have a good focus there. I still don't have it. I'm waiting for that to happen and then engaging again. And completing the goniotomy. Though I marked the end of the goniotomy, the trabecular meshwork did not really get detached there. So I'm just going back and removing the trabecular meshwork completely from there. Now it is completely detached. It's lying over the iris. I am removing it with a McPherson. So this is KDB and this is post-op day 30 gonioscopic image of this patient. Sometimes you may have remnants of the trabecular meshwork in some areas, but this is mostly completely done. So what evidence do we have to support the use of KDB? So this is an RCT which compared phaco KDB versus KDB, and they found that at 12 months, in 71% of the phaco KDB group and 68% of the KDB alone group, there was at least a 20% reduction from baseline. But there are also RCTs which have compared KDB phaco versus phaco and found not a very significant drop in IOP, though there was a difference between the phaco KDB and the KDB group. There is a particular RCT which did not find this difference to be statistically significant. And there are a number of retrospective studies which have compared KDB with other NEECs and found comparable outcomes. This is one which compares phaco KDB with phaco iStent and found comparable outcomes. And this is one, this and again a retrospective series in angle closure glaucomas which has found good results. So bent ab interno needle goniectomy is probably the most cost-effective NEECs that can be tried as an initial step when you are learning NEECs. So this uses a 25 gauge needle, the distal 1 millimeter of which is bent towards the bevel about 80 degrees, as you can see here. So it essentially mimics how a KDB looks, and the dorsal portion of the bent needle is supposed to protect the posterior wall of the Schlemm's canal so that it doesn't damage the posterior wall of the Schlemm's canal. And the thickness of this double blade is again titratable depending upon where you bend it. So you can adjust it according to your needs and essentially use it the same way as demonstrated now. Slide into the Schlemm's canal, it engages there, but it's very sharp, so it tends to come out sometimes. It's not as smooth as KDB, and this is usually what happens. There will be a lot of bleeding. So there are very few articles on BANG. This is a retrospective series. I think this is the major article which I could find, in which similar outcomes, about 20% reduction in about 70% plus of the patients, and a reduction in 1 or 2 AGMs have been reported. Tenito microhook ab interno trabeculotomy excises more of the trabecular meshwork. You can achieve almost 2/3 of the circumference of the trabecular meshwork can be removed with Tenito microhook. There are it's a set of 3 microhooks. You have a straight one, which you can do a trabeculotomy in the nasal angle using the straight one, and there are 2 angled ones which address the temporal angle. So the nasal goniotomy is done with the straight hook, and the angled microhooks are used to do a goniotomy in the temporal angles. So this is the Tenito microhook. The good thing about the Tenito microhook is it's blunt. It's not as sharp as the needle that you bend. So it actually goes and engages into the Schlemm's canal. So it is a little more controlled than bang. So you can see it going and engaging into the Schlemm's canal, and you can see the microhook a little bit through the trabecular meshwork. You know you are in the right plane. And here I am doing the inside out technique, and then completing to the other side also. So I have not done beyond the nasal goniotomy with Tenito microhook. When I want to do more than the nasal angle, I have now started doing GAT. I have been using only the straight microhook. But it is a very controlled goniotomy that you can achieve with Tenito. Again, there are a lot of retrospective studies on Tenito microhook. This is one series in 560 eyes where the mean IOP reduction reported is 31%. And there are studies which compare microhook trabeculotomy with suture GAT and find comparable, if not better, results. And this is a recent RCT from India in 114 patients. And they found a 50% reduction from baseline in the group which had Tenito microhook trabeculotomy when compared to phaco alone. And they found that the degree of trabeculotomy that is done did not really correlate with the IOP reduction. So complications, of course, hyphema is there in 90 to 95% of the cases. Some amount of hyphema will be there. Iridodialysis can be a dreaded complication. Long-term complications which are reported include elevated intraocular pressure, PCOS, transient pain, and reoperations for hyphema. My take on this, I feel it is definitely an option that you have to provide for patients with open-angle glaucomas, especially for those whom we are not planning a glaucoma surgery. And in elderly patients and patients with comorbid conditions who find it difficult to use medications, even in advanced glaucomas, I find that patients usually don't mind having an option like this. Patients have to be counseled thoroughly regarding realistic expectations that it is only going to reduce a medication burden. It's not going to take them off medications. Post-operative hyphema is almost always there. Post-op day one vision will not be like a cataract surgery. Stop anticoagulants 5 days pre-op. These three techniques are essentially similar, though KDB glide and Tenito microhook seemed a little more predictable in my hands. Just 1 minute, can I take? John? Yeah. Intracameral piloning helps better visualization. Having the phaco incision exactly at 9 or 3, that helps you access the nasal angle the best. Good visibility is key. Have a good subtenon block given a little earlier before surgery so that the bleeding from that stops. Have a clear corneal incision rather than a limbal incision. Get good control of the microscope foot pedal. Keep zooming in and out as you visualize structures. Use a good cohesive viscoelastic as already John had mentioned. And we have also found that using the cohesive viscoelastic at the end of surgery also helps to control the hyphemas. So this is what we do at the end of surgery. You keep washing till the bleeding almost completely stops, and then half fill the anterior chamber with the cohesive viscoelastic. Not completely fill it. The eye is still soft. As you can see, the eye is still soft, and then give a good tamponade with saline and form the chamber tightly. So this helps to prevent these dispersed hyphemas which can cause an acute drop in vision, and even if you have a hyphema, it will be more localized like this. So the vision will still not be hand movements and 1/60 which can make the patient panic. So we are seeing some good reduction in IOP, and there is a reduction in medications. The data is yet to be compiled. Literature is currently limited by small sample size, narrow spectrum of glaucomatous disease, and conflicts of interest. We need more evidence, and these techniques are definitely evolving, and there is a lot of future in most of these techniques, and it's definitely a graceful surgery to learn. And I see that in some way or the other, many of these techniques are going to stand the test of time. Thank you.
Thank you so much, ma'am, for your experience on all these types of MIGS. I know you have your vast experience on GAT also.